Thank you, Ian. So today we are going to have a CME for young gynecologists and also gynecologists in training. The topic of discussion today will be on capacity building, reducing barriers, and fostering advocacy, empowering young gynecologists for maternal health transformation. This is part of the FIGO Leadership Development Initiative, a project that we've been implementing in Kenya. And I'm glad that we've been joined by Dr. Maina Ngoigo, who is one of us. I consider him as my mentee, and he's been involved in this project also. So he'll be sharing insights, especially that will be useful for young gynecologists. But just before he speaks, I just want to take us through a brief introduction of or a bit of updates on the implementation of this project. So one of the key achievements or key deliverables for the project was about the goal setting and engagement with the stakeholders. So COGS part of the multi-country societies which are implementing the Leadership Development Initiative, most so focusing on two areas. One is we're focusing on emotive and also for anemia prevention. And one of the outcomes was to set goals in terms of engaging the Ministry of Health. And we've held inception meetings with the Ministry of Health and the 4 facilities that are involved in this project, mainly Meru, Kisumu, Voi, and Turkana. And the importance of the project is mainly advocacy for life-saving intervention, mainly advocating for the use of histobocarbetocin, especially for prevention of postpartum hemorrhage. One of the ways in which we've been conducting this project is by introducing a barrier assessment tool. And the barrier assessment tool is used to identify obstacles in providing effective maternal care so that interventions can be instituted. So the barrier assessment tool is used in the facilities. We're not going to the details of this. And the purpose of the tool is to identify knowledge gaps and systemic weaknesses, including supply chain issues, as primary barriers for achievement of optimal maternal health and maternal care. And the facility involved were prioritized these barriers and interventions to address them. And this is how come the leadership is important, because you as gynecologists will be involved in identifying barriers and gaps in the system that actually ultimately lead to maternal mortality. So in addition to what I've said, we know that everything starts and falls with leadership, and this involves the policy change, advocacy, and we have engaged government leaders and policymakers to strengthen maternal health policies, including meeting government ministers, senior hospital leaders, and other decision makers, with a focus on ensuring that there is commodity security, equipment are available, and even the issues with human resources for health. We have also developed knowledge and educational resources. And in relation to this, COGS has participated in the production of best practice resources that are related to anemia management and emotive. And this includes the management of anemia in pregnancy and also emotive for PPH. So the key outcomes of this project include creation and validation of a leadership training package. And we know that Dr. Maina was also involved in the development of leadership training package. This has been uploaded in the COGS e-learning portal and is available for those who may log in and participate in it. And in addition to this, the e-learning modules has included gender transformative approaches because we realize that most of the time the leadership of maternal health is top-heavy, led by males, and the frontline workers are mainly left for the female gender. So what we have achieved include the consideration of blood measuring devices as an essential in the essential medical supplies. I know as leaders we'll be involved in advocating for blood measuring devices for objective measurement of bleeding rather, and adoption of histobogabetosin for prevention of postpartum hemorrhage. And we have also achieved with the engaging Ministry of Health issuance of circular for prevention of anemia as a PPH mitigation strategy. And as a result of this, we now have an updated EMONC training package, including development of visual aids for emotive. And so we now have 3 documents that have been developed with the support of this project. This includes the revised guidelines continuum of care package for maternal health, the national guidelines for quality obstetrics and perinatal care, which has included the anemia management and emotive within the comprehensive care, including the preconception matters, whereby we've included management of anemia. So as leaders, it's good to have these very good documents, but now the issue will be how do we actualize them? How do we have them implemented, especially as young gynecologists? So having said that, I'm going to stop sharing and I'm going to invite Dr. Maina Ngoigo to proceed. Dr. Maina, the floor is yours.
Thank you so much, Dr. Elly. And I must acknowledge I'm able to present here because of your mentorship. So I'll be sharing my presentation. So I don't know, are you able to see my presentation?
It is showing Dr. Maina has started sharing. Yeah, now we can see it.
Okay, let me put it on slideshow. I hope it can be seen on slideshow.
Yes, we can see it. Thank you.
All right, so my name is Dr. Maina Ngoigo, obstetrician and gynecologist, and also LDI trainer, having undergone a comprehensive training through COGS and FIGO. And as Dr. Elly has correctly alluded, the purposes of this series of training and also the webinar is basically to capacity build, to bring on board leadership strategies that can help us to tame the burden that is PPH and anemia in pregnancy, not to mention the other stumbling blocks in attainment of quality maternity care. So in a sense, this presentation will not be it will not strictly focus on PPH and anemia, but will give a broader sense of how, as young gynecologists, as young specialists, we can leverage on our skills and our networking abilities to both advocate and also to initiate and sustain changes in the healthcare ecosystem to achieve better maternal health outcomes. So just by doing the obvious, maybe I might just need to emphasize these 4 terms. And capacity building, whereas I don't want to overemphasize its meaning, it's basically strengthening of skills and abilities to enable an organization or a team to thrive and also to transform what they have as a vision into a reality. If I was to take an example of, what Dr. Elly earlier, presented on, the efforts of LDI to tackle PPH would definitely require a lot of capacity building from obstetricians and gynecologists, midwives, and all team players, including laboratory personnel, management, to actually achieve the same goal of taming or stemming the maternal mortality rates that accrue from postpartum hemorrhage. One of the authors I love to read, and I'm still currently reading is called John Maxwell. And in the realm of leadership, he opines that a leader is one who knows the way, goes the way, and shows the way. And this begs the question, as young gynecologists who are either freshly from training and now are transitioning into the actual work on the ground, or the practical aspect of the obstetrics and gynecology work, or basically maternity care, where is our place in terms of building capacity amongst our teams, improving our own skill sets and sustaining them, as well as empowering those teams that we are going to work with, because we cannot achieve quality maternity care alone, because it's a team effort. Then barriers. This is, I think, self-explanatory. Barriers are basically, factors or anything that blocks or prevents achievement of a particular goal. And as you would imagine, there are several barriers in healthcare which prevent access to quality, equitable healthcare, as we are going to see. Amongst them, of course, would be resources, which can be human, financial resources, infrastructural resources, stockouts. So those are amongst the barriers that exist. And from the previous LDI series, the COGS LDI team had actually tried to seek to know what barriers exist in different facilities. There were 4 facilities that were, earmarked to give feedback on what barriers exist. And as we're going to see in the next subsequent slides, some of the barriers that were brought forward as what impedes achievement of quality maternity care. Then in terms of advocacy, where we also come in as team players and also team leads, these are basically actions that support or argue for a particular cause. And in this case, of course, the cause that we are pursuing or advocating for is improved maternity care. And maternal health transformation is the achievement, rather is the ultimate goal that we hope to achieve through the advocacy, capacity building, and elimination of these barriers. So why is this discussion important? Because as you can see from the statistics, they are not any encouraging. In the last about 10 to 20 years, actually, there has been a reduction in the maternal mortality ratio to around 34% globally, to 223 per 100,000 from 339 per 100,000 live births in the year 2000. Yet when you look at the statistics in our own country, it's still very worrying at 355. The set sustainable development goal of achieving less than 70 births per 100,000 live births by the year 2030, for us clearly looks like it's a tall order, seeing that we are only 5 years shy of 2030. And that means that we have to truncate these numbers by more than 5 times. So there's a lot of work to do. And as we all know, the leading cause of maternal mortality is a postpartum hemorrhage, and this contributes more than 20% of maternal mortality. Apart from the issue of maternal mortality, other areas of interest in the context of maternity healthcare or quality maternal healthcare include reduction in intimate partner violence, improving the statistics around anemia in pregnancy, which is part of the focus of the LDI, safe abortion care, family planning, amongst others. And it cannot be gainsaid that maternal mortality is basically a surrogate, of the status of the society or the focuses of the society. So some of the barriers that have been identified through these efforts by FIGO and COGS and this is a bit specific to PPH and anemia, but in a general sense, they are applicable to all other facets of maternity healthcare, include inadequate or rather inadequate trained skilled workers. So basically in the facilities, whether it's in the private sector, public sector, or even in the county facilities, you find inadequate staff who are adequately trained to conduct or to provide quality care. Sometimes also you find one of the challenges that has been brought forth is poorly equipped emergency rooms to tackle obstetric emergencies like postpartum hemorrhage, hypertensive disorders in pregnancy like eclampsia. And then therefore this begs the question, as a young gynecologist who is transitioning from being a resident, or actually you are in your early years of practice, how are you going to challenge the pre-existing cultures in the facilities that you're going to work? How will you challenge the dogmas of practice that have existed over the years? And you find that some of these cultures, which are non-progressive in some of our facilities, are already entrenched in some of the staff that work there. So if you go there and you're trying to initiate change, how can you take that space as a team leader to actually engineer this kind of change that you want? Then we have the perennial issues of blood products and inavailability of blood. And yet, as the team lead or the person with the highest responsibility in all pregnant women, as a young gynecologist, the buck still stops with you. How do you navigate providing quality care and at the same time dealing with the fact that you have limitation in terms of availability of blood products? Then there's of course the challenge of a guideline implementation of existing guidelines. And I think it's a common problem, I think in Kenya and probably in other sub-Saharan African countries, to have a lot of policy papers, a lot of guidelines, but stuffed in shelves without application at the at the facility level, or basically bedside, or basically at the point at which you are meeting these patients. Then there is the issue of high staff turnover. This has been a perennial problem. I think it's an increasing problem even locally, where you have skilled trained workers who are not able to retain their own employees. It's a problem both at the national level, at the county level. So if you have continually new employees who do not have the prerequisite experience plus the skills, meaning that every new cycle, every new season, your work is to actually train new people who you're not able to retain, then it becomes a problem even for the team that you're working with, or even for you as a gynecologist who is supposed to show direction or show direction to the rest of the team members. And I cannot overemphasize the issue of supply stockouts. I think this is something which we are very familiar with. I think in the course of training, some of the challenges I think we were experiencing was, having this, having stockouts of some very ordinary drugs, say nifedipine, some analgesia, and sometimes you think it's a very peculiar situation until you actually get to a facility where now you are the gynecologist and you encounter these challenges and realize it actually requires some systemic thinking to see how to tackle this problem. It's not like you're going to get some money from your pocket to purchase some of these supplies. It requires a team effort. It requires a multi-sectoral approach where you are engaging the procurement team, the hospital management team, the pharmacy, and of course the institution management, to see that you can stem the issue of stockouts. The impact of these barriers on health outcomes. Of course, some of the problems that we didn't maybe mention in the previous slides was, the issue of poor communication among its health workers, and this has been shown to contribute to more than 60% of all adverse health outcomes. This is as per a report by the Joint Commission in 2015, and this still remains to be a huge problem even in our local context, because sometimes you find that horizontal and vertical communication sometimes is a challenge, and a lot of details or a lot of important information is lost in between, and then there's breakage in the continuum of care. So how do we plug in as young gynecologists to improve effective communication, improve effective listening, and advance closed loop communication, where we are able to encode and decode information in a way that the entire team understands the objective and how to achieve that objective. And as you can see, the number of deaths attributable to safety incidents which are related to ineffective communication are very high at 3 million, and probably more in the global outlook. And I think maybe that very last bullet, which is specifically talking more about our own situation, you can see a report which was published by WHO that showed that in lower and middle income countries, one of the problems is having skilled birth attendants as one of the barriers to achieving quality maternity care. And we seem to be achieving only 68 to 78% averagely, compared to high-income countries who are achieving about 99%, skilled birth attendants. In Kenya, there's disparity between the urban areas and the rural areas, and therefore that means that even as doctors, as clinicians, as health workers, as young gynecologists, how are we going to bridge this barrier by empowering the teams that we are working with, empowering the nurses, the midwives that we are working, the clinical officers, because as you can imagine, there are limited human resource in the sense of specialist obstetricians, yet the population is ballooning every other year, and therefore, what opportunity do we have to improve these statistics of skilled birth attendants, while at the same time balancing the interests of all the stakeholders, including those who control the resources. So for us to be able to address these barriers, we then have to do what is called, sort of like a SWOT analysis to see what strengths do we have as a health ecosystem, as gynecologists, as practitioners. What are our strengths? Which areas are we strong at? Are we strong in the skill level and probably weak in the communication level? Is that the gap that we are likely to plug? Are we strong in the skill level, in the communication level, but probably we have challenges with, say, something like technology? So it means that in that sense, one of the opportunities that we see in that is maybe leveraging on technology to be able to plug in the gaps of continuum of care and also standardization of care, so that we can improve the outcomes and standardize care across all our facilities. So we have to evaluate not only ourselves but also the team that we are working with from the dimension of the strengths that we have in the teams, the weaknesses that we can work on, who are the people that we can maybe say sponsor for further training, who are the people that we can put in leadership positions, what are the opportunities that we see? Is it to bring on board other stakeholders? Is it to bring on board people who are in management? Is it to actually involve even the politicians? Is that the opportunity that we have to tackle this problem? And I think I might draw inspiration from in this sort of analysis. I remember in the last Congress when we saw the governor of Makueni coming actually to put statements on the need to equip our facilities with heat stable carpetosin, something that has been implemented in Makueni County. And definitely that means that there's a team behind the scenes who have actually managed to bridge the gap with the politicians and saw it as an opportunity to actually bring them on the discussion table to show them the need to have these quality medicines stocked in our facilities. And of course, we have to marry the issue of the performance, knowledge, and attitude, so that we can be able to leverage on our leadership skills, our communication skills to be able to achieve those goals. So, in a sense of a summary, to address these barriers, we have to enhance effective communication, which advances the understanding of every team member and clearly articulates the goals that we want to achieve in terms of attaining quality obstetric practice. We have to foster and to engage in more collaborations with other team players, because it's not our prerogative alone as gynecologists or as doctors to actually advance quality health practices or quality obstetric practice, but it also relies on a team. It's a web of other team players, whether it's the laboratory personnel, whether it's the midwifery team, whether it's the pharmacy industry, whether it is the procurement departments, because without all these team players, then the whole cannot hold. All of us have to plug in so that we can be able to achieve the same objective. And in the course of doing all this, we have to remain adaptable. And adaptability comes in the sense that there are set objectives that we want to achieve as young gynecologists, as ambitious and as enthusiastic as we would want to be. But we're also operating in the context of sometimes limited resources, whether it's financial resources, physical resources, human resources. Sometimes they are limited, yet that is not excuse. The client, at the end of the day, expects the highest standard of care. The client will not understand whether you're having limited staff, whether you're having an availability of oxytocin or heat-stable carpetosin, or the graduated gowns for PPH. The client expects a maximum or the best possible care, because that is their constitutional right. So how can we remain adaptable to work within our constrained resources and still yet give the best out of these scenarios? Some of the ways to address some of these barriers, and I think this is one of the areas where, as team leads, as gynecologists, because in the maternity department or maternity context, you as the gynecologist in this facility, you are actually the biggest advocate. You're actually the team leader who must show direction. So are you advocating for more trainings and skill development amongst your teams? You as a gynecologist, are you also taking more trainings to develop yourself? Because remember, any skill unutilized is like a muscle. It will undergo atrophy. So even the skills will undergo decay if you do not actually do continuous application and also continuous learning. Are you engaging in things like, let's say, point of care ultrasound, which has become now, even the Ministry of Health is actually adopting because they have realized it has a lot of benefit in terms of improving obstetric practice. Are you as a gynecologist advocating for your the staff who are below you to go for this kind of trainings? And then, I mean, are you also, looking for other opportunities to look for more strategies to improve your own practice? When we talk about new approaches like the emotive, which has taken years of research and has been approved as a, as a fast response bundle for PPH, have you taken time as a gynecologist or as a team leader to actually equip your team or create champion teams that can actually tackle PPH following the emotive protocols, or are we still stuck to the old practice of approach to PPH? So that we don't have new published evidence, yet we are still stuck to the old ways of practice. So as young gynecologists, are we able to actually translate the science that we have learned into actual practice on the ground to transform healthcare? Then in terms of team and capacity building, we've talked about the issue of equipping with being equipped with the skills, and also on job trainings, as well as promoting teamwork, improving the skill level of our teams through drills, workshops, trainings, training, even things like EMONC. Assess the training needs of your department. Will you just go back and land into a facility or into an institution and just continue the old way of doing things? Or are you actually going to look at things in a macro way to see what are the gaps that we can plug in, which are the areas that we can try to improve on? And of course, although this has still been a challenge, but it is believed that ring fencing of resources and also specific allocation of particular resources for maternity healthcare would actually see a realization in improved maternity outcomes. So in terms of, continuing the discussion on addressing these barriers, how are we improving our communication skills? We already say that poor communication contributes to more than 60% in sentinel events. And some of the tools that we can use is using a closed loop communication approach, using of the ISBA tools, encouraging constructive feedback. So there is the issue of communicating as well as listening, effective listening to understand, taking constructive feedback or even criticism accurately, because at the end of the day, we have to be audited by the systems, and we have to also audit ourselves for purposes of improvement. At the same time, you have to also remember collaboration enhances teamwork. So as young gynecologists, as team players, how are we able to leverage on teamwork to collaborate with others to maintain professional, that respect between teams, but at the same time, leverage on our own strengths and our own skill set to be able to contribute to the same objective of achieving transformative maternity care. And as you can see on that small diagram, how to have a closed loop communication that ensures that the person sending the message, if for instance I'm a gynecologist, and let's say the medical officer or the registrar, or even let's say the intern or the midwife is actually consulting me regarding a particular mother who is in labor, or a mother who is having postpartum hemorrhage, am I able to actually understand the message that has been passed across? Am I able to understand the urgency? Am I able to communicate back to the team on orders or on particular instructions that can be followed? Or am I creating ambiguity? So we always have to aspire to be clear in communication, and most importantly, to ensure we are using the closed loop approach to communicate. Then how does advocacy then come in as a tool of transformation? We've already seen that advocacy is basically, trying to argue for a particular cause or to support a particular cause. And we already know that advocacy in whichever sector, and especially in maternity healthcare, leads to improved quality care and improved outcomes. And this is in a way in terms of helping our team to achieve our objectives, improving our hospital statistics, improving our departmental outputs, supporting patients to navigate the healthcare challenges, being advocates of the patients, and of course, building networks that will help us to bring in more resources, whether it's human resources, financial resources, into our own practices to support our work, so that you are not a frustrated young gynecologist trying to make changes, trying to, I mean, the wise men say that no man is an island. Even if you're the best gynecologist somewhere, you must leverage on the power of the network that you have to actually, effect any change that you desire. What are the interests of the stakeholders? You must find out the community that you are serving. What are their interests in improving in the sense of trying to improve the maternity health care? What is the government's interest? The development partners, the NGOs, non-governmental organizations, what are their interests in the context of healthcare? How can you bring them on board to actually bring in their expertise, to bring in their resources, to train even more people, or to capacity build, to be able to help you achieve that objective of quality, obstetric or maternity care. And when you talk about quality maternity care and improving obstetric statistics, we cannot forget, the former FIGO president, when he said that women are not dying because of diseases we cannot treat. They are dying because societies are yet to make the decision that their lives are worth saving. Are our governments committed? Are they actually putting resources with a focus on changing the trajectory of our MMR numbers? Are our governors, wherever they are, the ministers, are they actually geared towards prioritizing maternity health care so that they support the work that we as gynecologists do to be able to tame these statistics? As gynecologists, are we going out of our way to create awareness about these numbers? Are we going out of our way to talk to health administrators? Are we going to talk to the CECs and the county directors, the chief officers? Are we seeking audience with the ministerial departments that can actually bring on board resources and put the issue of maternity care as a priority area of investment, or as something that is worth investing in, and not just any other tenet of of healthcare? And how to build advocacy. Anytime you want to build advocacy, number one, you must have data and evidence so that you're able to build credibility among the stakeholders. Secondly, effective communication strategies, which include effective listening. I've already mentioned applying data and evidence, as well as expertise. There's the issue of proper utilization of resources with proper accountability. So advocacy goes hand in hand with accountability, because, for instance, if you're trying to to seek for support from donors, they of course want to see in your previous projects, how have you actually utilized the resources that you've been supported with previously. So it comes in with the issue of proper utilization of resources, prioritization in priority areas, and accountability, monitoring, and evaluation. So that at the end of the day, what we want to achieve is reduced maternal mortality and even newborn mortality, empowering our women, because when more women survive, they are more productive to the nation. They enhance nation building, and we have healthier societies. So what are the action points for advocacy then? As gynecologists, remember we said you are at the pinnacle of that ecosystem. You are at the leadership position. So it is you to guide direction, guide in creation of policy, adoption of this policy, drive research and collection of data that can support your advocacy. Because remember, we have said there's no advocacy without hard evidence and data. So are you actually in a position to actually influence or to engineer research that is geared towards improving, maternity and reproductive health, statistics? Building, public engagement and involving the public and other stakeholders, and then also, of course, educational activities, and also providing mentorship. So as a gynecologist, as a young gynecologist, your work is not to just treat the patient, but also to empower those people who are below you, vertical mentorship. So if I'm a gynecologist, am I actually empowering the medical officers by training them on strategies to, for instance, tackle PPH? Am I able to empower them by training them on the emotive in a practical sense, not just on just training platform, but even how that translates on the ground? Am I able to actually create teams that can respond to emergencies? Am I able to create teams that can actually be involved in evidence, generation of evidence, data collection, research? Am I able to pass information by educating, whether it's the clinical officers, whether it's the nurses or the midwives? Are we able to institute mechanisms and tools of monitoring our progress? So are we able to do baseline data analysis before we put in any interventions? Are we able to do progressive monitoring to see whether the interventions, whether it's in terms of communication or resources or trainings, that they have an impact? So if, let's say, the intervention is actually doing drills or training people on PPH or taking people for an EMONC workshop, what are our numbers before and after the training? Are we doing the monitoring and evaluation? And then one of the other important things, which I think is probably has been put on the back burner, is the involvement in policy and the political landscape of, of whichever jurisdiction. You find that sometimes as doctors, as gynecologists, you are very well trained. You have the information, you have the skill, but we become very shy of confronting the political class. And we very well know that the political class are the ones who control the resources, which are to be directed to the priority policy areas. And these policy areas are developed by the technocrats. So you as a gynecologist, you're the technocrat. You have developed policies, very good policies, very good protocols, good guidelines. But remember, to actually operationalize these guidelines requires resources. Now, unfortunately, these resources are controlled by majority of the times guys who don't understand the priority areas, the needs, and even the urgency, or even how critical some health outcomes are. For instance, like in maternity, if we are talking about something like PPH, how do we make governors, how do we make the ministers to actually realize that instead of, let's say, for instance, the minister may be saying that there are enough gynecologists in the country, yet you know that with the kind of population that we have and the kind of MMR statistics we have in the country, vis-a-vis where we need to be by 2030, obviously we don't have enough gynecologists. So how are we equipped to face the political class head on, to be able to bring this sense to them, so that as gynecologists, as young gynecologists, we are not overwhelmed by the fact that we don't have support. We are not being understood by the political class, so that we move away from complaining and whining to confronting solutions at the table of discussion. Remember, they say that if you're not at the table of discussion, then you are the menu. So how do you confront those people who control resources to actually prioritize things that matter to your work? So it's also your work to be involved in guidelines development and protocols, to advise on policy direction across relevant ministries and government departments, to collaborate with other players, as well as most doctors, actually not just gynecologists. One of the challenges we have, even today, whether senior or junior doctors, we do not seem to understand even some of these basics of health planning, budgetary processes. Like if you're mandated to run a particular maternity unit, if you are asked to bring up a quarterly budget for your department, what are these itemized budgetary items that you're actually going to put on that budget planning cycle? Are you well versed with the budget making process? Are you able to objectively ask for particular resources because you already understand the needs of your department? So it definitely translates to the fact that as gynecologists, one of the other areas that we have to look into is empowering ourselves with understanding the financial planning, budgetary cycles, and how this is related to resource allocation at both the local level, at the national level, and even at the facility level. And then, as we said, as gynecologists, remember, you are the team leader in whichever capacity that you are in. So you have to be the engineer of research activities, encourage research, so that you have hard data which you can use to advance your advocacy activities. Because remember, without data, without evidence, then you lack credibility. And if you lack credibility, you're weak already on the advocacy front. Then you must also institute mechanism to actually do monitoring and evaluation, so that you're able to tell whether your interventions are actually working, so that you can be able to tell in which areas are you likely to need to redirect the resources, so that you do not focus resources on things that do not work. You focus resources on things that seem to be taming or bringing down the negative statistics that you have. And then, of course, creating awareness through community engagement. So as a gynecologist in your facility, are you actually involved in knowing Why is this community having persistent high prevalence of anemia in pregnancy? Is it a dietary problem? Is it a transport problem that they're not able to come for antenatal care? Is it that maybe the roads are impassable? Is it that these people are actually jobless? Is it actually that people are having a lot of intimate partner violence, which is prohibiting them or precluding them from visiting antenatal contacts? So are you actually able to assess this, the sociocultural determinants of healthcare, which eventually will impact your care? Because if consistently you have mothers with anemia in pregnancy, then at the end of the continuum, it is you, the gynecologist, who will have to handle the issue of the increased risk of postpartum hemorrhage because of this anemia. So are you going to the root? Are you conducting a root cause analysis of the problem that you are seeing at the clinics? Are you going to talk to the community leaders to find out what's the problem at the community level? Are you engaging other stakeholders? Are you also going to the media to create more awareness? Because without awareness, then there's less absorption of the information that you want passed across to the societies, and you don't want the communities to get information from data media, from social media, a lot of myths. You want to debunk these myths by engagement in media outlets or infographics that can pass more information. Of course, as we said, we must always remain adaptable to take up new evidence-based approaches to improving maternal care. As Dr. Elly already alluded, part of the work that COGS has been doing through the LDI is actually trying to bring the issue of leadership in adopting these new strategies, like application of the emotive protocols by training gynecologists, training other healthcare providers on how to apply the emotive protocols. Are we also adopting the use of heat-stable carbetocin? It's been shown that it's effective and non-inferior to to oxytocin. Yet we know the challenges that we have with oxytocin, the cold chain in our facilities. Yet you'll find that because of that breakage in the cold chain, you get ineffective or oxytocin that is not effective. You continuously have postpartum hemorrhage, increased strain on the healthcare system and the healthcare workers. Yet, by maybe applying something like heat-stable carbetocin, which has no challenges with storage, you could stem all these problems, improve maternal health outcomes in terms of reducing postpartum hemorrhage, and even reduce the stress and the strain on the healthcare system. So are you remaining adaptable and adopting the new evidence that is also being generated? Are you able to see the gaps and plug in so that you can implement the new strategies? So the WHO has these building blocks for strengthening healthcare systems. And as a young gynecologist, your role, as we said, you're in the leadership position, is to ensure there is proper service delivery, empowering the health workforce, ensuring there is proper staffing who are well trained, dissemination of information through trainings, ensuring through collaboration that there are available medical products, blood products, vaccinations, relevant technologies, that can help in either telemedicine, teleconsulting, or even health systems, technology that can help you in standardizing of care, even bringing point of care ultrasound, for instance, in your respective maternity units, point of care hemoglobin assessment in the clinic areas. Are you able to advocate for ring fencing of resources? So financing, remember, all these activities are dependent on resources. Are you providing leadership and governance? Because remember, for healthcare to succeed, it's a factor of proper leadership and proper governance, and that's the only way you're able to achieve, improved healthcare, deliverables, or basically statistics, to have a better and responsive healthcare that is not reactive, but rather it's proactive, and improved efficiency at the workplace. And improved efficiency leads to better teamwork, reduced burnouts, and more team collaborations. So as the leader of your team in your area, you're the vision bearer. So what vision, what's the objective of your team? Have you shared the vision? Has everyone understood that we want to break, or rather to bring down the numbers from 355 to 70 in the next 5 years? Have you discussed what are the steps that you're going to take? What are the practical steps that you're going to take as a team to actually stem down, if it is the number, if maybe the maternal mortality ratio that you're talking about? How are you going to bring down the prevalence of anemia in the population that you're serving? How are you able to boost learning and constructive feedback, enhancing training for your own staff and also for your own sake. Are you able to foster collaborations and networking with other staff members, other stakeholders, those people who provide resources, the other partners and development partners? Are you able to enhance effective communication in the department as a practice? Is it part of your institutional protocols to use, for instance, the SBA tools, to use tools for monitoring and evaluation? Is it one of your habits to actually collect data so that you don't just practicing the practice of obstetrics and maternity care, but you're also doing that and collecting data for purposes of improvement? Because without collecting data, you will not know where you are, neither will you know where you want to go. And also, of course, the issue of advocacy, so that you generate internal support from your own team members, from your own departmental colleagues, from hospital administrators, from other departments that are meant to support the departments of obstetrics and gynecology or maternity. So, what are the take-home tenets from this discussion? As we try to light the fire in the young gynecologists who are either training or even the ones who are just who are being released into the market. Remember always, as a gynecologist, you are a team leader, meaning you are there to inspire, to empower, and to strengthen your teammates. Is it strengthening your colleagues horizontally? Is it vertical empowerment of your other junior staff, the medical officers, the interns, other team players like the midwives? As the young gynecologist, are you just having the enthusiasm and the skill set, but are you able to absorb the new paradigms so that you translate from theory to practice? Basically, what you call the translation of science, the research skills, the new evidence. Are you able to translate it so that it can lead to better outcomes for our mothers? Are you able to scrutinize and understand the existing barriers? So are you able to collect information on what barriers do exist and bring on board people who can help you to stem the barriers? And it's also your work to foster effective communication, train your teams, take courses, study if you must, so that you improve effective communication at the workplace. Because remember, without effective communication, gaps will exist in care. These gaps will lead to poor maternal outcomes. Then don't forget, neither should you shy away from taking up leadership positions. Take leadership positions, get through the mud, know the challenges, face even the political class, those who control resources, go on a round table, bring the issues on board, make maternity healthcare or maternal healthcare a priority or an area of discussion. Let it be on the menu. Let it not be on the back burner. Bring it on board, amongst government personnel, amongst development partners, even amongst hospital administrators or facility administrators, so that the resources can actually be directed to priority areas that will lead to improved and transform maternal health outcomes. And then one last thing is to leverage on professional societies, like for instance COGS, to be able to navigate the barriers in provision of quality healthcare, and to be able to increase our voice in advocacy and systems strengthening. I think with those few considerations, I would want to open the floor for discussion or maybe for more additions, and I thank you.
Thank you very much, Dr. Maina. It's always a pleasure listening to you and bringing forth these insights that you have encouraged us to not to shy away from leadership, and also to engage the political class. We as gynecologists, we are team leaders in our little microcosms, whether you are in your small facility or you are the county gynecologist. We have a responsibility to kind of spread our influence in a positive way. So I'm going to open it up for discussions, and if, I don't know, Ian, do we have the rights for people to ask questions, or they have to type?
They can put up their hand and I can unmute them.
Okay, and Dr. Maina will take all the questions.
Yes, I'm on board to advance the discussion.
Thank you. Any questions, so that we only have 5 more minutes before we wrap up? I don't see any hand that is raised. Oh, Ian, you can see from your end.
No, none from my side.
Okay, let me just going once, twice, and thrice. Therefore, I'll take it like there are no questions rather. These recordings will be available for those who may want to interact with them further. And thank you very much for attending the webinar. God bless you all and have a nice weekend.
Thank you and bye to you all.